And the question is, what do I think about it? Well, obviously, I think quite positively about it from what I've said earlier on. It's certainly not the standard diet that is recommended by the Canadian Diabetes Association. The Canadian Diabetes Association's recommendations and the general kind of dietary recommendations that you hear from health professionals in the main are essentially modifying the current diet that we have. So there is still processed foods involved. It's a question of what you want to do. I don't think there's any overwhelming evidence either against or for historic diet. To me, it just makes a lot more sense because, again, we're going back to what we were designed for. The question is, what were we designed for? In my mind, we were designed for that, and that's why that sits better for us.
Okay, so I do have questions.
All right.
Okay, one person asked that their fasting glucose blood test, the normal range is 3.5 to 5.5, but this person's glucometer normal range is 4 to 7. Have normal range changed?
Okay. All right, so I mean, I wouldn't get too hung up about that. Here's what you need to know. If you have diabetes, you should be running your sugar between 4 and 7. Fasting and up to 10 after food. Okay, so that's essentially it. I wouldn't get hung up about normal ranges, glucometers, all that stuff. That's really the goal. So if you're checking your sugar, you should be running between 4 and 7 fasting and up to 10 after food. And that's an hour or two after food. If you're outside that range, then you're too high and something needs to be done about it. I wouldn't get worked up about the 0.5 and the point. They're really meaningless in the great scheme of things. They're more of an interest from a scientific point of view and in research. But for you personally, your target needs to be between 4 and 7 fasting and below 10 after food.
Next question. This person has type 2 diabetes and was recently prescribed a new medication called Januvia. Please provide me more information on this medication.
Okay, so let's talk about the medications in general because that's a huge issue and many people will have specific questions which hopefully I'll be able to touch on in this part of the discussion. So how do I feel about medications in general? People say to me, you know, I want to treat my problem naturally. I don't want to use drugs. I don't want to use medications. And ideally, that is my preferred approach. Ideally, I would like us all to be able to treat this problem without medications. But you know, you reach a certain point where you cannot solve the problem or even improve it without medications. And so that has to be part of the management for a significant proportion of people. Certainly early in the disease, if you can be more physically active and watch what you eat, you can get away with not being on medications or on smaller doses. But sadly, regardless of what you do, as this disease progresses over time, you have to take medications. And it's simply a question of balancing risk against benefit. So sure, all drugs have risks, but the risk of the disease and the consequences of having uncontrolled sugar and the other metabolic problems associated with diabetes far outweigh the risks of medications. So, what are the medications? Well, most people will start off with metformin. Metformin is pretty much the cornerstone of treatment. It's a standard drug. Some people use it even before diabetes develops in a phase called pre-diabetes because there's evidence that we can prevent progression to diabetes by using that drug. Metformin is very safe. It's been used for more than 50 years, and it's a very effective medication at lower levels of sugar. But after a while, and as I said, this is a progressive disease and the sugars tend to increase over time. The insulin production decreases over time. You need additional medication, and typically the commonest drug after that is glyburide, although there are a variety of other lookalikes like glyburide, one of which is gliclazide. Some of you may be on that one. Then there is a third category of drugs which is completely new, and that's what Januvia is. Januvia is a drug called sitagliptin, and it works very differently from those first two categories. So how does metformin work? Well, metformin works in the liver by making less sugar. Your body actually makes sugar. It makes it in the liver, and if you can switch that off, that will reduce the amount of sugar that is around. The other category, the glyburide that I mentioned, that works by squeezing more insulin out of the pancreas. And that is a typically standard drug. The third category, Januvia, works very, very differently. It works on another set of hormones called the incretins, nothing to do with insulin directly. And the incretins act on the pancreas to release more insulin. Januvia works by increasing the incretin level, which indirectly increases insulin levels. Januvia has been around for about 5 years now. It's fairly safe so far. We know that people that take it have been perfectly healthy in terms of long-term consequences. We also know that it helps people keep their weight stable. Most other drugs will make for increased weight. That's one of the challenges of treating diabetes. And it's also associated with no hypoglycemia. It doesn't lower sugar below normal. So one of the challenges of managing diabetes is that sugars can go low, and with Januvia it doesn't. So that's a major advantage for that drug. Okay.
All right. This person asks, is it enough to just have their A1C test instead of taking daily blood samples if your A1C is 7 to 7.5 regularly?
That's a great question. And I caused a huge controversy with my colleagues about 2 or 3 years ago, because I don't think people need to test their sugars every day. It actually, it's an interesting problem. But if you think about it, why do you test your sugars? Okay, so I'm talking about people here who aren't taking insulin. I'm talking about people that are just taking or on diet or on physical activity and diet or on medications like metformin or Januvia. And for those people, testing sugars on a daily basis doesn't add anything to what you do, okay, except for costing money and pain in your fingers, okay? In fact, you should save all that money for the future when you may need to go on insulin, and then you need to test your sugar, because insulin can cause hypoglycemia and you need to adjust the dose of insulin based on what your sugar is, so you need to know what your sugar is then. But when you take metformin or Januvia or are just on a diet and exercise, there really is no benefit from testing glucose, with two provisos. First of all, I do advocate that you learn to test your sugar when you're first diagnosed, so that for the first 2 or 3 weeks, as you modify your diet and your physical activity, you can see what effect the food that you eat has on your sugar, what effect your physical activity has on your sugar. But after a while, you learn that that triple cream milkshake is going to raise your sugar. Testing it isn't going to contribute anything, so there's no real point doing that. The other point is that we have a far better test, and that's what was alluded in the question, the A1C. So what is the A1C? The A1C, some people may know it as the hemoglobin A1C. The A1C is a test that we do every 3 months that gives us 3 months sets of values for blood sugar. Essentially what it is that we all have sugar in our blood, and we all have blood cells that circulate. And as the blood cells circulate in the blood, little bits of sugar get stuck onto it, okay? So little bits of sugar get stuck on. And that happens to everybody because we all have some sugar in our blood. But if you have diabetes, your blood cell is going to get more sugar on it because you've had more sugar in your blood. So if we take that blood cell and measure how much sugar has got stuck onto it, we know exactly how much sugar there has been over that period of time. Let me give you an analogy that will be quite clear to you. Let's say that you want to know how much rain has fallen in Vancouver over a 3-month period. One way is every few hours to look out of the window and see whether it's raining and to note it down. A far more accurate way is to put a container outside and let it rain. It will rain, the water will collect, and you can measure exactly how much rain has collected. Okay? The first method of looking every few hours to see whether it's raining or not is not very helpful. It doesn't really give you a good scientific amount. The other one, which is far simpler and much less time-consuming, of collecting the rain, just leaving that thing out there and seeing how much is collected, is far more accurate. So that's the difference between the blood sugar and the A1C. So the A1C gives you 3 months' values of how much it's rained in Vancouver, how much sugar you've had exposed to that red cell. The person with insulin treatment needs to know on a daily basis, several times a day, what their sugar is, because they need to adjust their insulin. So it's a different story altogether. So if you do have type 2 diabetes and you're not on insulin, stop testing that sugar. You do not need to test it on a regular basis. I gave you one proviso, one exception, which is when you're first diagnosed. The other is if you feel unwell. If you're not well, you need to know what your sugar is, because if it's too low or too high, that can be significant. So if you're not feeling well, you've got a sickness, you're nauseous, or you've got a flu, you need to know what your sugar is. And so that would be the other time to check it.
Okay, there's a second part to the question. If your A1C is 7 to 7.5 regularly, is it okay to stop 15 milligrams of Actos if I am also on Janumet 51,000? I am gaining weight and retaining fluid.
Yeah, so that's a very, very specific question that it'd be difficult for me to answer without actually being your doctor and doing a full assessment. But let me give you a broad guideline, and that is that if your A1C is being maintained at the target, which is actually below 7. Some people, we have a relaxed target of 7.5, but generally it's below 7. If it's being maintained by medication, then stopping the medication is going to raise it. Okay? The only time that we would discontinue medication is if it goes down too low or you're getting significant complications of the medication, side effects from the medication. Now, he mentions or she mentions weight gain, and unfortunately, weight gain is almost a standard expectation in the treatment of diabetes. It sounds bizarre, I know. There is a deal with the devil here in that diabetes is a consequence of being overweight or partly of being overweight, and the treatments that we use often cause more weight gain. Not all of them, but some of them. But the challenge is to get the sugars down, and it's a balance of one risk against another. Yeah.
Okay. Please comment on the study of diabetes patients given 500 calories per day causing a reversal of diabetes.
Yeah, so if you starve people, if they dramatically reduce their food intake, then you can significantly affect diabetes. It doesn't cure diabetes. It certainly dramatically reduces glucose problems. But there are two challenges. The first is that you cannot maintain that kind of caloric deficit for very long. And in fact, what happens is that people that lose weight and have improvements over that period of time will then rebound and then regain a lot of weight. You see these adverts all the time. You know, you see these photographs of people with, with their previous sets of pants, and they're like sitting there, and like three people would fit into that pair of pants. All those people, almost invariably, I can tell you, will regain the weight that they lost. So anything that leads to dramatic weight loss of that ilk generally results in regain of that weight. So I don't advocate any of those treatments for the simple reason that they cannot be a long-term solution. They only work in the short term, with one exception, and that is surgery. So we know that surgical interventions, people call it stomach stapling, gastroplasty, there are different terms that are used, but essentially what they involve is restriction of the stomach. We know not only that that leads to weight loss, but also that that weight loss is sustained and maintained. Secondly, we know that that results in reductions in some of the complications of weight problems and of diabetes, and we also know that there is a higher cure rate of diabetes than with any other approach. So I'm a very strong proponent of gastric and other forms of restrictive surgery, and I think that they should be more commonly available in Canada.
Okay, next question. Is there a relationship between reactive hypoglycemia and diabetes?
Yes, there is. People who have reactive hypoglycemia don't have diabetes, what happens to them is that they eat food and their insulin levels rise very, very high, much higher than a normal individual, and they drag down the sugar after they eat. And for those people, the treatment is actually to eat their food more spread out so that they cause less insulin rise. So they basically ask them to graze rather than to eat individual meals. And that condition is associated with a family history of diabetes, and those people are often underweight at this point in their lives, but as they age, it's usually young women that get this, as they get older, as they gain weight, they'll be more likely to develop diabetes, and it's part of their family history often.
Okay.
Yeah. Sorry, did you have a supplementary on that? Yeah. So the answer is yes, there are a number of studies, but specifically in type 1, there is a study called the Diabetes Control and Complications Trial, which is probably the single most important study in diabetes. And they showed very, very clearly that the A1C was the factor that determined the complication rate. So in a sense, it really doesn't matter from a practical point of view that you have these oscillations as long as the average is normal. Okay, so sure, there can be problems with hypoglycemia and there may be problems with hyperglycemia in terms of symptoms and immediate consequences. But if you're able to tolerate those, as long as it all comes out in the wash type of thing, as long as the sugar average, which is the A1C, the average exposure is in the normal range, then the complication rate is low. And that's been proven. The other factor here is time, all right? And so if you have good control for a long period of time, that's wonderful, and that reduces your risk of complications. But ultimately, things are going to happen, and hopefully they can be minimized, and clearly they have. You've done very well. But this is a difficult thing to say to people, but we're all going to have problems in the end, and so you want to minimize that and reduce the level of complications as much as possible. And so, just to both of you that asked the question, the A1C, whether you have type 1 or type 2, is the best guide to those complications. And so if your A1C is, as it is in your case, in the normal range, then you're going to have less in the way of complications. And you've done very well. I mean, if you've been on insulin for 70 years,
well, not 70.
68, you said.
The record is 83.
The record is 83, yes. Well, it's going to get up there. Okay. Next question.
My parents do not have diabetes. My nephew has type 1. My sister has type 2. My fasting glucose is 6.7, A1C is 6.1, and BMI is 26. How am I doing?
You're doing fine. Here, a couple of things from that question. The first point that I want to make is that type 1 and type 2 are two very different diseases, and they're actually not related. So if you have a family history of type 1, that doesn't mean that you're at risk of type 2. Secondly, the familial part of type 1 is much less than type 2. Type 2 is much more commonly familial, has a much higher familial predisposition. With regards to those particular measures, 6.7 fasting is pre-diabetic. And 6.1 A1C is also, by the new definition, pre-diabetic. And for people with pre-diabetes, that means that their sugars are a little bit higher than normal, but not in the diabetic range. You are on course to develop diabetes over time. There are no guarantees of anything, but you're definitely on course and at risk of progressing to diabetes. And therefore, there are a number of recommendations for those people. And the first, of course, is to lose weight if you are overweight, to increase your physical activity, and to watch the dietary elements that we've spoken about. I really can't stress physical activity enough. For most of us, the amount of physical activity that we do is going to determine how long we live. So it's very important that you all find some form of physical activity that you can maintain. Now, people get funny ideas about this. They think, oh, I've got to run in a marathon, or I've got to do some dramatic sport. It's actually completely the opposite. The thing that you have to do is something that you're comfortable doing and that you can do on a regular basis. One thing that you don't need to spend money on special equipment. Walking is a great exercise as long as you do it vigorously and regularly. And what do I mean by vigorously? Well, you need to be able to just about maintain a conversation, but you should be able to notice that it's not easy to maintain a conversation because you're walking fast enough to make it more difficult. Obviously, it helps if you've got somebody with you, because if you're having a conversation on your own, it's a bit funny, isn't it? But having a buddy is a huge advantage to making sure that you have exercise, because sometimes you don't feel like exercising and sometimes they don't, and you can buddy up and keep each other going.
Okay, this is a nutrition question. What is the importance of the glycemic index in diet?
Yeah, so the glycemic index relates to how quickly sugar gets into your blood. And there's a fair amount of controversy over this, but I fall on the side of the believers in the glycemic index. What it means is that the quicker the sugar gets into the blood, the more insulin is, and more quickly insulin is released, and the more likely that sugar is to get stored as fat. The simple answer is that you need to have foods that retard the absorption of sugar, that are as little processed as possible. It really relates to one of the earlier questions. So these processed foods, anything that contains flour, refined carbohydrates, sugars, pure sugars, those are the things to be avoided. Those are the high glycemic index sources. The low glycemic index are the ones that are more slowly absorbed, are associated with less of an increase in insulin, less of a strain on the pancreas, less weight gain. I personally find that if I stop eating refined carbohydrates like bread, pasta, rice, I can lose 20 pounds in a month or two. It has a dramatic impact for me personally, and I find a lot of men particularly have that phenomenon that's really quite dramatic. And actually, my sugar also, I'm not diabetic, but my sugar also falls with those kind of restrictions. Fortunately, we all like bagels and croissants and those things that are bad for us. Yeah.
How do you feel about chemical sugar when you desire something sweet?
Yeah, I'm not a big fan. I think you can train yourself to not have sugar rather than having those sugar twins or the sugar fakes or whatever you call them. First of all, they're chemicals. They're chemicals that potentially have consequences that we don't really know about. They're certainly not natural. Secondly, there is some evidence that they actually stimulate appetite. That the sensation of sweetness, but without delivery of something sweet, makes you go and get something sweet later on. And so there is some suggestion that people that use that actually gain weight. I'm not a big fan of that, or of carbonated drinks that have artificial sweetener in them. There isn't good hard evidence on that, but there are some studies that suggest that there is some weight gain that occurs with those. So my simplest recommendation is to avoid them, because you can actually train yourself. Remember, we weren't designed to eat sugar. We weren't designed to have that amount of sweetness in our food. And so we can actually train, and similarly with salt. People are like, ooh, that doesn't taste good, it's got no salt in it. But actually, very quickly, if you reduce your salt intake and reduce your sugar intake, you will find that the food tastes absolutely fine and tastes normal. It's just what you've adapted to getting used to. So I would just say, cut it. Years ago, I cut out sugar in my coffee. I don't miss it at all. I don't have any sugar in my coffee.
The time is 8 p.m. Visiting hours have ended for today.
Okay, you gotta go.
Okay, next question. We often read in newspapers that some conditions like insomnia or kidney disease lead to diabetes. Is this true? Which comes first?
Okay, so kidney disease is straightforward because kidney disease is actually a consequence of diabetes. So this is a broad comment I want to make. Diabetes damages small blood vessels. High sugar essentially damages the blood vessels and blocks the little blood vessels so the blood doesn't flow through them. And there are various places in the body where that leads to problems. The first one that was already mentioned is in the eyes, and that's actually a window into diabetes because you can look into the eye and you can see those small blood vessels and you can see how they can get clogged up and damaged, and we can see them directly with an ophthalmoscope. And so that's one very important area where that damage takes place. The other is the kidney. And kidney disease is a very common and often important complication of diabetes. And then the third area is in the nerves, in the blood vessels that supply the nerves, and that's why people get funny sensations and lose sensation in their feet, toes, and sometimes in their hands. Having said all that, the key to preventing those complications is, first of all, good sugar control, but also being proactive about the damage that takes place. And let me give you 3 examples. With the eyes, it is absolutely critical that everybody with diabetes sees an ophthalmologist, an eye doctor, not an optician, not the guy that tests your eyes for whether you need glasses or not, but a MD, a doctor who specializes in eye disease. Why? Because the damage that happens is preventable, not just by reducing blood sugar, but by the treatments that the ophthalmologist can use. And they can actually prevent blindness. Remember that diabetes is the single commonest cause of adult onset blindness. And you can prevent it by A, getting good sugar control, and B, going to an ophthalmologist regularly and getting reviewed. I bet you go every year to an ophthalmologist.
Right now, every 6 months.
There we are.
I'm putting injections in the eyeball.
Right, okay. So here's our poster boy for good diabetes care. So every year for somebody with type 1, and with type 2, it really depends on where you are in the disease, but probably at least every 2 years. In terms of kidneys, the first thing that we pick up are protein leakage in the urine. And so if you have type 2 diabetes, your doctor should be doing an annual test of your urine to check for protein leakage. Once you've developed protein leakage, they may not be testing every year anymore because you're already on treatment for preventing progression. But before the treatment starts, you should be getting that annual test. And with the nerves, the commonest problem is damage to the toes, to the feet, ulcers, cuts, wounds that result in amputation. And so the third thing of those 3 things that I'm telling you about, the third thing is you should always look at your toes every day. Every day before you go to bed, you should kiss your toes goodnight. You'd have a look at your feet and make sure that all your toes are present and correct. And I'm being a bit facetious, but what I mean is that you need to look to see whether there are any cuts or ulcers or sores. And here's the point. Diabetes results in very, very small reductions in your sensation, your ability to sense things happening in your toes down there. The reason why we get pain, what's the purpose of pain? It's to alert us that there's a problem. So when you cut yourself or damage yourself or have an ulcer on your foot, you have pain there in order to tell you not to walk anymore, because if you walk, you'll cause further damage, and ultimately that is the kind of thing that leads to gangrene and amputation. In diabetes, you don't have that pain, you don't have that alert, so the only thing you can do is you can actually look at your feet and make sure that there's nothing there. And if you see an ulcer or a wound or a cut, you need to make sure that your doctor sees that, because it can go from very bad to an amputation before you know it. Something to be aware of.
Okay. Have you heard of diabetic
There was another part to that question. Sorry. Yeah. It was about kidney disease.
Insomnia.
Insomnia. Yeah.
Sorry.
Okay. So insomnia is not directly related to diabetes as such, but we do know that sleep disorders, difficulties with sleep, are associated with weight gain and with diabetes as a consequence of that. Sleep apnea is probably the most important. Yeah.
Okay. Have you heard of diabetic gastroparesis, which is neuropathy of the stomach, and have any information from studies about the treatments that work and or long-term effects if it may cause a type 1 brittle?
Have I heard of diabetic gastroparesis? Okay, well, I'm the professor of diabetes, okay? So if I hadn't heard about it, I'd be writing, you should be writing questions to UBC. Okay, so...
City doctors for 3 years never told me about it.
But they might not have been diabetes experts. So diabetic gastroparesis, was the question from you? Okay. The diabetic gastroparesis is a complication of diabetes that happens because of damage to nerves that supply the stomach. And the stomach is actually not just a thing that sits there that collects food. It's actually quite complex, and it has nerves that control it and control its contraction and coordinate its contraction with the metabolic processes that take place in terms of food absorption. And what happens in diabetic gastropathy is that the nerves are damaged, and so the stomach doesn't contract properly, and there is a mismatch between the contraction of the stomach, the absorption of food, the insulin, and so on. And you can get into a right mess, and there are a number of different problems that can arise: poor food absorption, wild swings in blood sugar, and problems with nausea and vomiting. And those are all big challenges. There's some interesting new developments in that. One of the things that they're looking at is using a pacemaker.
I tried.
Okay, that didn't work for you. Often the biggest challenge is adjusting the glucose to the food absorption. And I think ultimately for most people who have gastroparesis, the most effective approach is to use a pump, insulin pump, with a glucose sensor so that there is a continuous, So you don't have that?
We once did.
Yeah.
Something bad happened to the pump and it broke.
Right.
And we didn't have the money to replace it.
How long ago was that?
That was in 2007.
Yeah, so the pumps are progressively getting better, and certainly the pumps that come with a monitor that continuously monitor your glucose are the most effective.
We did a 2-week study on
Right.
it recently with the one in the hospital.
Right. Yeah, so that would be the most effective thing, I think.
Are there any experts, or diabetic doctors that their expertise is gastroparesis? Could you find any?
Ever.
Well, there are. It's gastroenterologists that have more of.
They don't understand the diabetic aspect.
Let me talk to you a little bit afterwards. Okay. All right.
Okay,
Next.
there was actually a second part. Would gastroparesis cause a type 1 brittle diabetic? Someone to become a type 1 brittle diabetic?
It was asking about long-term complications from having gastroparesis.
So gastroparesis, it's the other way around. Having poorly controlled diabetes leads to gastroparesis. Gastroparesis makes it difficult to control type 1. So, yeah.
Okay. Is it true that diabetics should not eat more than 1 egg per week? If yes, why?
No, it's not true.
All right. Do we have any more questions?
Yep.
What do you think of dogs for diabetics?
Yeah, I think some people, for warning for hypoglycemia, it's very interesting. Nobody knows exactly how it is they can sense the low sugar, but some people have remarkable stories to tell about being saved by dogs. It really depends on whether you have a problem with hypoglycemia and prone to hypoglycemia. Really, the best approach is to use treatments that don't lead to hypoglycemia. And although that's easier said than done, we do have newer insulins and monitors that allow us to reduce the risk of hypoglycemia. And ultimately, that's going to be better than a dog. A machine that can read your sugar and tell you your actual level and give you an alert is going to be more accurate more often, I think. Although it's nice to have a dog.
What about during the night when you're not?
But you see, those machines can they will alert you, wake you up. Yeah.
How about stress and diabetes?
Okay, so the general question about stress and diabetes. Stress can be a factor in raising your blood sugar, but it isn't specifically a factor in diabetes as such. Certainly, stress is bad for anybody's health in general. I recommend that if you have stress, that you try and reduce it. And the best way to reduce stress is to be physically active. Yeah.
I'd like to hear you comment on beverages, alcohol, wine, drinks, that sort of thing. Low sugar or no sugar, pop.
Okay, so I'm not a big fan of any kind of pop. So I would basically eliminate that whole category of food to substance, whatever you want to call it. Actually, do an interesting experiment, all of you. I mean, most of you will go to the supermarket from time to time. I want you to actually walk down the supermarket aisle and identify how many things you see that are actually healthy. I mean, 80% of the food in the supermarket is processed food that's basically garbage. And it's been sold to us and forced upon us, and we're slaves to it. It's totally unnecessary food, totally unnecessary. I have no need for it whatsoever. All the good stuff is in the first couple of aisles, the fruit, vegetables, some of the cereals and grains, and then you start getting into rows and rows of processed garbage. So just get back to your question. No need for pop whatsoever. Completely eliminate all sugar drinks. In fact, they've made great headway in the States reducing those sugar drinks in schools in terms of reducing some of the obesity in kids, because those are empty calories. They're completely unnecessary calories. The second question about alcohol. Alcohol, people tend to think of alcohol with tobacco, and they're two completely different things. Alcohol is actually quite beneficial to health in modest amounts, okay? So I'm not talking about somebody who's an alcoholic, all right? If you're an alcoholic and you have a substance dependency, this is not applying to you, all right? You need to avoid alcohol because you have a dependency. But if you don't, there is evidence that suggests that a small amount of alcohol is actually healthy and results in a longer life. So people that have a small amount of alcohol live longer than people that have no alcohol. But don't get too excited. We're not talking about huge amounts of alcohol. We're talking about a glass or two of wine per day at maximum, and certainly no more than that. In terms of types of alcohol, wines, beers, there isn't really a huge difference in terms of benefit. Yeah. Yeah, so fruit juices, again, if they're naturally squeezed stuff, that's one thing, as long as the quantities are not huge. But you have to be very careful about the processed stuff, because a lot of it is artificially sweetened and has additives, fructose, all kinds of things that are not good. So you need to be careful about when you have these when you have so-called fruit juices, how natural they are. In every way, that's bad. Okay, so we talked about the small blood vessels and how they're damaged by diabetes. Cigarette smoking essentially compounds those specific issues, so it damages exactly in the same way. It's like adding oil to fire. It really is a very bad mix. So cigarette smoking is bad for everybody, but it's particularly bad for people with diabetes, and so it certainly should. If you have diabetes and you're smoking, for goodness sake, stop, because that is the worst thing you can do for your health, is smoking, for anybody, but particularly for somebody with diabetes. Yeah?
Are there some fruits you should avoid?
Well, there are some fruits that will raise your sugar more than others, but in general, if you're having a decent diet without a huge amount of excess fruit, then I don't have a problem with it. Like I said, it's more the processed stuff that I have a problem with. Yeah. You will find that some fruits will increase your sugars if you check it, but as long as you are moderate in your consumption of those, then that's fine. Yep. Yep.
Is there a particular kind of heart disease that's associated with type 2 diabetes?
Yeah, a bad one. Yeah, so it's not too dissimilar in terms of the type of problem, but there are two specific things that are different. The first is that the damage is further down the artery, and it's more diffuse. So in general heart disease, the damage is in the blood vessels at the beginning of the arteries to the heart. Remember that what we're talking about are the blood vessels that supply the heart itself, the heart muscle. And in general, the type that cause heart attacks are bigger clots in the big vessels. In diabetes, the damage is further in as the vessels get smaller. And secondly, the diabetic heart disease is generally more silent. And what I mean by that is it doesn't cause chest pain in the way that non-diabetic heart disease does. Diabetics have a much higher risk when they have a heart attack of having a bad outcome from that heart attack. And so it's very important to prevent heart disease in diabetics above and beyond what we do with people without diabetes. Yeah.
Is Vanderbilt's disease in any way related to or precursor?
Is Raynaud's?
Yeah.
No, not related at all. Totally separate. Yeah.
Dark chocolate good?
Is dark chocolate good? It actually is. I don't mean it's just good to eat. There is evidence that chocolate is associated with a reduction in heart disease. Now, that doesn't mean that you should go off and have vast quantities of chocolate, but a modest amount of chocolate from time to time is reasonable. And the other thing I say to people who are on a diabetic diet is, for goodness sake, allow yourself to enjoy life, okay? If your sugar is up from, once in a while, it's not the end of the world. If you're having a slice of birthday cake, that's fine, all right? Just don't have half the cake, all right? Have a slice, like a normal person. No, I mean, we all like to have cake. Just be careful. Allow yourself to enjoy from time to time. But, have an extra slice or a slice of birthday cake and then go out for a walk. Allow yourself an indulgence from time to time. You don't have to make your life miserable, but just be cognizant of that. Yeah. Yeah.
Many years ago, I read something about stem cell research that's been applied as possible answer to diabetic.
Yeah, so the issue with diabetes, of course, is that the pancreas is in type 2 is making less and less insulin over time. In type 1, has stopped making insulin right at the beginning. And so how can we bring the insulin back? Well, at the moment we use the chemical itself, the molecule insulin, we inject it back in. But wouldn't it be ideal if we could get those cells to make insulin again, or in fact, bring those cells back to life? And one of the challenges of biology is that when cells turn into a particular type of cell, a pancreas cell or a heart cell or a brain cell, they stay as that cell type and they don't make more of it. Okay. What a stem cell is it's an embryonic cell from embryology that can become any kind of cell. Okay, so it has the potential to become any kind of human cell. And so the idea is that we take these cells, we put them back in the pancreas, and they turn into pancreas cells, and they make insulin. And that would be the perfect solution to diabetes. This is still in the realm of science fiction, but there is work that's being done that is making it closer and closer to science fact. And I would actually predict that within 15 years, we'll see stem cells actually being transplanted to make insulin and essentially providing a cure for diabetes. Yeah.
Did Calgary have islet transplants?
It's not Calgary, it's Vancouver. Excuse me. Yeah, Edmonton is where you're thinking about. That's where they had the big splash. But where the real work is being done is in Vancouver. No, so we have an islet cell transplant program. It's not stem cells. Here's what we do. We take islet cells from donors, from the pancreases of people who've passed on, and put them into people with type 1 diabetes, and those cells will make insulin. Now, the difference between a stem cell and a transplanted cell is that a stem cell is your own cell, okay? It's a cell that you don't have any immunity to, okay? You don't have a problem, you don't have an immunity reaction to it because it's your own body. The problem with taking somebody else's cell, a donor, is that you have an immune reaction. And that's the challenge. If we didn't have immune reactions, we could solve all our medical problems with transplantations. The problem with transplantation is the challenge of the immune problem that happens. And so we are doing islet transplants here. We have a special immune treatment for it. But I wouldn't recommend it currently as anything other than research for people because it's simply quite complicated and it doesn't cure the problem. And you have to go on immune treatments. So, but watch this space. Give it another 5-10 years, and we're making great progress. And who knows, maybe more mainstream therapy. But it's Vancouver, not Calgary.
It was Calgary originally.
It was never Calgary. It was Edmonton originally.
Was it?
Yeah. No, there's nothing going on in Calgary. No, there's lots of good stuff in Calgary, but not in this area. Yeah. Yeah.
Comment a little bit more about the gastric stapling
Yeah.
and how that cures diabetes, and at what point would one consider that, and how complicated is it?
Well, it's a very interesting thing, but the reduction in food intake that takes place as a consequence of the gastric operation results in changes in blood sugar that happen almost immediately, within days. It's a very, very effective treatment for diabetes. It's still somewhat controversial, and it's certainly not available routinely in anywhere in Canada, and certainly not in British Columbia. We're really lagging behind in terms of being able to offer this kind of surgery. But again, I believe that within the next few years, we're going to see much more of it. In the United States, more and more insurers are using this treatment because they find that it's cost effective. It actually results in less healthcare costs. People who have their diabetes cured don't need medications for their diabetes and all the cost that there is for that. They are more able to work. They don't have to have days off sick. So for the insurance companies, who are the providers of healthcare in the United States, it actually makes a lot of sense. Unfortunately, our provincial governments haven't quite worked it out. And so they're paying for all these other things. They're paying for medications and all the complications of diabetes. They'd be far better off paying up front for the surgery to reduce the risk of progression of diabetes to these complications, rather than waiting for the complications to come up. Yeah.
Getting back to your islet cell transplantation, which obviously is an excellent program, are you suggesting that sometime in the next 10 years it may be possible to do that without taking immunosuppressant drugs? Because the long-term side effects of immunosuppressant drugs with any transplantation are far worse than the
Absolutely.
side effects of
Which is why the only people that are having islet cell transplants are people who really have severe complex diabetes with major complications, and often are having kidney transplants as well, which means that they have immunosuppression for that reason. Yes, I think that the exciting thing about the research that's taking place now is that we're learning how to alter cells so that they will make insulin. And so either using stem cells or other cells from our own bodies, alter them in order that they will produce insulin. And that is a potentially exciting thing. 5 years may be early, but 10, 15 years, yeah, absolutely. Yes, for sure.
They said there'd be a cure for diabetes in 5 to 10 years in 1989 when I was diagnosed. 5 to 10 years later, still heard 5 to 10 years.
Well, it's a moving target, but I think some of the molecular biology research that came to the fore around that time looked like it was going to yield results quicker than it turned out to be the case. But there's no question that in 100 years there will be no diabetes. I have no question in my mind that in 100 years the problem will be solved.
Now
Question
I
is,
figure out how to live for 100 more
right?
years.
The question is, well, actually, the likelihood is significantly higher for all of us that we'll live beyond 100 than it was for our parents and grandparents. Secondly, the question is whether, the next 10 or 15 years, and again, I think it's highly likely. So I always tell my patients with type 1 or type 2, you need to keep yourself as healthy as possible because in the interim, because in time, we're going to have a solution to this problem.
That's actually a question I have.
Yeah.
People do have complications.
Yeah.
Let's say in 10 to 15 years there's a magic would the damage that was done previously be able to be fixed over time as you have better control, or would it be just too bad?
Well, it depends on which specific type of complication you're talking about. For example, if you've had severe damage to your eyes and you're blind, it's unlikely that it's certain that reducing blood sugar and normalizing insulin and so on is going to bring that back. However, in terms of things like nephropathy and so on, it's quite likely that some of that's going to be reversible with better control that might happen. Yeah. It's very, you're asking a question that's very difficult to answer specifically to a given individual. We do have any other questions? Or are people keen to get off to go and see the Canucks lose?
It's 1-1.
It's 1-1? It's 1-1, yeah. But it was that first period, right?
Yeah, LA scored first. Can we switch to a screen?
Unfortunately not. Okay, yes?
This is maybe simplistic, but given what we know now and to treat, can diabetes be cured, or do you just maintain more of it?
No, it cannot be cured as such in that sense. What you can do is you can prevent or delay the progress to diabetes. So essentially what you need to think about is as this conveyor belt that's leading us all to diabetes as the pancreas diminishes in its ability to make insulin. And what we do with our preventative treatments is that we move you earlier on in the same conveyor belt, but as you age, you're going to keep moving back in that direction. So, I mean, that is one of the challenges of aging. In fact, it's a very simple equation. Most people over the age of 80 have some degree of diabetes. As you get older, the risk significantly increases. And so we just keep people younger for longer. Yeah. On the skin? I have no thoughts on coconut oil. But if it's a natural oil, it's going to be healthier.
I just was wondering because when I went to go and have some blood work, I had been told it was really good to be using it. But when I went to go and have some blood work, my levels were quite high.
Of coconut oil or the? I don't know.
So, I mean, that was from going
Yeah.
to, having it somewhat healthy.
Right.
Thinking, and
I think probably in moderate amounts. It's probably layer it over everything. Yeah.
Would you take a few minutes and talk about some of the research that you're personally involved with?
Yes. So some of the research that I'm doing is on how we deliver healthcare, how we can get better diabetes care in the community, how we can get people under better control. And a lot of it's to do with this issue of owning your own health and how you interact with the healthcare system. The fact is that, I'm very pleased at the turnout here, and obviously people are very interested in looking after themselves here, and that's why you're here. But unfortunately, the vast majority out there are not. They're very passive about their diabetes and their healthcare issues. And that's a big challenge. And how do we activate people to have a better understanding of their personal health and so on? And one of the ways that we're doing it is actually working much more with nurses who go out into the community or work more directly with patients and help them navigate through the healthcare system and help them better understand their disease and better access to the resources that they need in order to get their diabetes under control. So that's the kind of research that we're doing. That's one part of my research, is actually looking at ways of delivering healthcare better that result in better outcomes. Other things that I'm doing involve new drugs, so drugs that you wouldn't have heard of, but new potential treatments for diabetes that involve different kind of approaches. We have a very interesting new drug that we're looking at that works by causing the kidney to leak sugar. So if you think about it, you take in sugar, and it goes into your body and gets stored, and gets stored as sugar and as fat. But it also gets taken out of the circulation to the kidney and then goes back into the blood. And if you were able to stop the kidney from reabsorbing the sugar, it would all get poured out and you'd lose it. And there are two things that would happen as a consequence. Number one is you'd lose weight because the calories are being lost in the urine. And number two is your sugar would go down. And that's exactly what happens with this drug. So potentially an exciting treatment that simply involves taking 1 tablet a day, losing weight and losing sugar by peeing it out.
Isn't that like leaching?
No, it's not like leaching because there are no leeches involved. There's pills.
What makes the sugar come out?
It's a pill that works on particular cells in the kidney and stops them from reabsorbing the sugar. It's kind of magic, but it's science.
What's the estimated time before that might?
About 2 or 3 years. Yeah, and actually it will work in both type 1 and type 2.
That was my next question.
Yeah. Yeah.
What's it called?
Well, there are a number of different drugs, but the one I'm talking about is dapagliflozin, which is a bit of a mouthful. But when it comes out, it'll probably have a simple name that you can. But it works in the kidney by causing the kidney to leak glucose. Yeah.
What kind of complications does that cause?
Great question. So it's pretty safe in general, but if you think about it, if the urine is sweeter, then it's going to attract bugs. And so there are problems with urine infections and in women, vaginal infections. Not a huge problem, but it's just a slightly increased risk of that. Probably with good hygiene, you can help reduce the frequency of that, but that's an important problem. No, I don't think it will, and I'll tell you why, because the history of weight loss pills is not good. There's been some disasters in terms of, first of all, everybody wants to lose weight, so these drugs are often abused. So I think pharmaceutical companies have learned not to go after that particular indication. And so there are a couple of drugs currently available that we use for diabetes that are associated with weight loss, but nobody's marketed them as a weight loss drug as such. And I think this category probably won't be marketed as a weight loss drug either. But we'll live and see. Yeah.
At one time, wasn't diabetes diagnosed because there was sugar in the urine?
Yeah, you're absolutely right. Diabetes actually means too much urine. And there were two kinds. There's diabetes insipidus and diabetes mellitus. Insipid means it's tasteless, and mellitus means sweet. And the physicians in those days would taste the urine, and they would say, oh, that's sweet. You have diabetes mellitus. And if it wasn't sweet, they'd say, oh, you have diabetes insipidus, 2 different conditions. Doctors were much more dedicated in those days. It's been a while since I tasted urine, I'm telling you.
Didn't they also use Actos to, I've heard that the ancient Egyptians used to pour urine ants, so if the ants went to the urine,
Right.
they knew they had the starving disease if they didn't.
Yeah, absolutely. Yeah, their ants are much more...
Better than the doctor.
Yeah.
Honey replace the artificial sweetener?
Can honey? Yeah, honey is a good sweetener because it's natural. But again, it's still glucose. It still will raise your sugar, but it's a better sweetener. It's certainly healthier. And that's what the ancients used to use for sugar. Yeah, at the back.
Would it be better to stop the sugar from being absorbed and to go to the blood, or would there be any...
We're talking about this particular drug, or...
Yeah, you say the drug will use or excrete the sugar
Yeah.
because it's already in the blood. I know you mentioned the mechanical state in the stomach, that kind of caloric intake.
Yeah.
Are there any kind of chemical or like pharmaceutical methods of stopping the sugar from being absorbed in the intestine?
Yeah, so actually there are a couple of drugs that have been used for that. There's a drug called Actos, which is currently being used, which delays the absorption of sugar. But that doesn't actually result in any weight loss. It's interesting. The sugar all gets absorbed, but it's just delayed. But it does help reduce the amount of insulin that's response, and so it does actually lower blood sugar in general. And the other is a drug that blocks the absorption of fat that leads to weight loss. But in general, that drug causes quite bad diarrhea. So neither of these drugs are particularly effective for what you're looking for, unfortunately. Surgery is still the most effective way of restricting caloric intake. So I think, we have one here. Yeah. The CDA have all kinds of resources, and the best place to go is www.diabetes.ca. That's the Diabetes Canada website, and they have a huge amount of resources that you can access through there, including books, recipes, and so on. Your local diabetes center will also have information on that. Yeah.
Just looking through that handout, it says that you're at higher risk if you had a baby that weighed more than 9 pounds. I'm just wondering why that is.
Because any woman that has gestational diabetes is going to be at higher risk of developing type 2 diabetes later on in life. Gestational diabetes is diabetes that occurs during pregnancy, and it's because the hormones that are produced by the placenta counteract insulin. They act against insulin. And the consequence of that is that the baby gets bigger because it gets more sugar. So big baby, big high levels of sugar in the mother result in a bigger baby. And so that's an indication of gestational diabetes, and if you have gestational diabetes, you're more at risk of developing type 2 diabetes later on in life. Have we exhausted the supply of questions?
Vancouver's up by 1.
Oh, great. Good time to stop. Thank you very much. You've been a wonderful audience. I'm really glad that we had good interaction. And I do recommend that website for the Canadian Diabetes Association. And if you have any more questions for me, you can, through the St. Paul's Foundation, I'll be happy to take them.